All right, good morning, everybody. Welcome to the second quarter CCT Collaborative. Once again, we're joined by a great group of folks here. So we got a good case. This one's coming from us here at Lifeline, a unique case that we had a month ago, something like that, a month or so ago. So as always, we're going to introduce the panel. So you guys all know who I am, unfortunately, because I'm the one that is always running my yap during these. So I'm Sam Mattan, one of the group care transport nurses for Lifeline. And we are coming to you live from the Special Operations Medicine Conference in Raleigh, North Carolina. We got invited down here to teach ventilator management. So I've got Dr. Margolis and Dr. Troncoso with me. So I'll let them say hi.
Hey, everybody. Ace Margolis, thanks for joining. Look forward to reviewing the case.
Hey everyone, it's Ruben Troncoso.
All right. And then we have the illustrious Dr. Ben Launer with us. Say good morning, Ben.
Morning.
And we got Jeff Nussbaum with us. Thanks for joining us, Jeff.
Thanks for having me. If you need me to come and show a Hamilton ventilator down there, I'd be happy to show off the ASV mode.
We got two. So we're repping both the Zoll, because it's a military conference and that's most of what they have, and the Hamilton, both the Zoll and the Hamilton folks were nice enough to loan us some ventilators for this course.
If
So
they have a Tempest monitor, let me know how that works. I'm actually very curious.
Yeah, I would assume they do. So we'll try and get into the expo hall and we'll report back to you, Jeff. And then I think the last person we got on our panel is going to be Kosh. Oh, and Arissa's on. Oh, thanks for joining us, Arissa. So Kosh, say hello.
Hi, everyone. Good morning.
And then Arissa, our shock trauma trader from Hopkins. Say good morning. She's back. I forgot. Welcome back, Arissa.
Thanks. Morning.
Good morning. How are you?
Good.
All right. So, oh Lord, it's a fire. So we're going to review, and I'm going to kick this to Jay Lohman here in just a second, the paramedic that was on this call. But this was a burn case, and I'll let Jay give you all the details. So, Jay, there's your dispatch, right? That's about what you guys got going out the door. Is that pretty much true?
Yes. We were told 63-year-old male. Didn't know at the time how many percent, like how burned he was. Just involved in a house fire, and we were going to St. Agnes because EMS en route to the burn center lost the airway. So that's what
Okay.
it was.
So they were headed to the burn center and diverted for airway management.
Yes.
Okay. So my question to the group is, as always, we sort of say, what do you want me thinking as I head out the door for this case? So like Jay said, we got house fire, EMS diverted to a community hospital. They were headed for the burn center. They knew they needed a burn center. So apparently a fairly extensive burn. And they diverted for airway management. What do you want me thinking as I head out the door? Jeff, why don't we start with you?
As you go out the door, I mean, so you know a lot about this case. I mean, there's like, we don't always get the full pathology. It's like, oh, septic shock. Well, what's the source? It makes a big difference if it's pneumonia or UTI. This is obviously someone with extensive burns. So fluids, pain management, big for burn management. And then, of course, the airway, I guess we don't really know if it's secured and what it's secured with. I'd say that would be the biggest thing. You always want to think of the biggest life threat. And in my mind, maybe you know this already, but if you just know that they're intubated, I mean, they could be intubated, it could be a supraglottic airway. That's always going to be the major concern. They're not, I guess you could be thinking about escharotomy somewhere in the back of your mind. Those are relatively rare, especially in our setting. But my big concern would be, is this a real endotracheal tube, or did they throw in a supraglottic airway and they're just punting?
For sure. Asa, got anything to add?
Agree with everything Jeff says as usual. I guess the other thing is I'm planning on being surprised to what their actual total body surface area involvement is, because traditionally we are very poor outside. If you talk to the burn center, everybody's very poor other than the burn center. But generally speaking, we were poor in general at estimating an accurate total body surface area that's burned. So I'm thinking like, boy, I really wonder what it's going to be. And I won't be shocked if it's either way less or potentially way more. That's one. And then two, what are the other sort of secondary pathophysiologic effects sort of at the cellular level that you're going to run into with a person being in a house fire, right, in an enclosed space. So all of those other things like CO and cyanide and anything else that is liberated from the combustion of whatever is in this house.
Arissa, as our resident airway guru, as an anesthesiologist, what are you thinking from an airway management standpoint? What are our biggest, what do I need to be most afraid of if I have to instrument this airway, right? They go to the ED at the outlying facility, they can't get it. They're like, why don't you give it a shot? What are my biggest concerns? What are the things that I'm going to worry the most about?
Biggest concern is airway edema and thinking you can get it in and then you can't pass the tube.
So am I prepping the neck sort of preemptively? Am I going a tube size smaller potentially? Sort of preparing for that?
I always make sure I have a bougie available in case you can't pass, and then always a smaller tube. I don't typically go for prepping the neck because if you're going to have airway edema, it's typically even going to be lower than where you would do a crike.
Okay, so crike is 50-50 shot, right? Flip the coin on the crike. Okay. All right. Anybody else on the panel have anything to add? Ben, I know you got something.
I'm just surprised that they were able to penetrate the force field around a local hospital to get there. So, the challenge is you're bringing the hyperbaric chamber and the cyano kit. I totally agree, and I would emphasize a couple of things. I think we overthink the burn estimation quite a bit. The research is terrible on us figuring that out, and I think we do far better looking at an app or some computerized or other way to estimate burn severity. Even though we stink at that, we're very good at determining what is and what is not severe. Totally agree with airway management. We have to remember that we have a lot of tricks. It is not an operating room, and looking at or thinking about a cricothyroidotomy is, I think, probably first and foremost in your airway plan, especially because supraglottic edema is going to make it very worse. So I think that's something just to be prepared for the full spectrum of airway management. But I think you hit the nail on the proverbial head there with fluid resuscitation, temperature management, pain control, airway management, and everything else like that. I think those are the big ticket items.
I think one last thought to add. I usually like to, set your mindset. Is this someone you're going to run in there and run out because they're going for an emergent thing, procedure, whatever? Or is this going to be like more towards the stay and play? We're going to fully resuscitate. We're bringing the quaternary care to them. And this one is not really clear to me. Sepsis, if they're bacteremic and there's presumed source control, like you have pneumonia or UTI without kidney involvement, or there's no abscess in intra-abdominal abscess, those people, you can really resuscitate them in place. And it's not clear if they're going for like long-term burn management or there's a reason they're getting rushed out of there and you need to go in a hurry. And I think that's one of the bigger challenges because you have to discover that and decide that on your own, in addition to practicing medicine.
Good deal. Any alibi fires? Any last things from anybody before we move on? Kick it back to Jay to give us the rest of the case. All right. Jay, give us the rest of what you saw. Or Emma, you're on too, Emma. So we have both the nurse and the medic that were on this call.
Okay, yeah. So we grabbed the cyano kit and the trusty epoch before we left. We got a little more info on the way. Let's see. Yeah, showed up. Luckily, like I said, I'll just read this I want to jump ahead here. Patient's house was reportedly exploded, caught fire. Possible meth lab is what we were told. EMS on scene, finding him at the front yard. EMS was en route to the burn center and became unstable and decided to divert to the sending facility. So,
and then this, I think, was sort of the course of the ED, and maybe you can fill in what you guys sort of saw when you showed up, but this is essentially what you found, at least from the chart, from what I threw on these slides.
Sure. Yeah, so we got there and thankfully he had a secured airway, was intubated endotracheally. All he had going at the time was just fluid, no sedation or anything. So we right away jumped onto sedation with fentanyl and propofol. The labs are as follows. He was significantly burned, more than I thought he was going to be burned, like Dr. Lawrence said about being surprised. And it was literally basically from the waist up, mostly anterior, and then almost circumferential around the right side on the chest. He was tachycardic when we got in there, obviously because of no sedation. And obvious airway burns. He had like a mustache, and you could see the airway was singed. Yeah, that's where we're at.
All right. So labs are somewhat unremarkable, except for, and I got to uncover this on my screen, for that gas is just garbage. And it's kind of not good. But would you say that gas sort of took you guys by surprise? That he didn't look that sick, like that acidotic, or did he look that sick when you guys got there? Like somebody with a 7.0 gas.
Yeah, he was not. He was not comatose. He was like responding to us, like moving his extremities, ones that he could, without pain, when we got in there. So yeah, that gas is definitely.
So probably worse than you would have guessed if you had to guess at what the gas looked like. That. And when I saw this gas and sort of talked to you guys about it, I was like, gas looks out of balance with what I'm seeing from a clinical standpoint.
Yeah, I would agree with that.
Okay. I think they're on the next page. Actually, they're not. What were the vent settings that you guys found the patient on? Do you remember?
Yeah, I think it was just your standard assist
Standard EE
control
settings.
Yeah, like 400, 450 at tidal volume, 5 a peep, maybe an 8 a peep at the time. And then like a breath rate of like 14 to 16, what I can remember top of my head.
Okay.
And so as far as access, he had an IO placement in the right. And then we kind of right away got onto, I went to go set up the vent while Emma got on the phone with our MDocs and started consulting for, the course, how we should tackle this.
So, Eric, Garfinkel, I didn't see you on. Dr. Garfinkel, you took the call on this one, correct? You were the medical director on this one?
Good morning. Kind of. We were in conference, and so the entire medical director crew was able to take the call. But technically, I was the one on call, yes.
Yeah, but if I remember right, it was a group effort.
That's right, a group effort.
Emma had to jump off, unfortunately, so she was the one consulting with you. But it sounds like you immediately sort of wanted to get control of analgesia sedation on this person, wanted to give the cyano kit, and then wanted us to get point of care labs, and sort of give you a call back for that same reason. Was the reason for the point of care just that the labs were old, or that they sort of looked out of balance with what we sort of expected from a clinical presentation?
Yeah, can you go back to the previous slide? If I recall, I don't think all the labs that we wanted were there. Specifically, I think I was looking for a lactate with the potential for cyanide poisoning given in the history. And then we wanted to repeat the blood gas too, because of how profoundly acidotic the patient was, so we could titrate the ventilator settings appropriately.
Okay.
Yeah, when we were in the room, I don't actually remember hearing this gas because I don't feel like that was addressed at the time. That may have come back after.
I'd say certainly looking at that gas, you have to have a high clinical index of suspicion for elevated lactate secondary to cyanide. Nobody's going to run a cyanide level on a patient. If they do, it's probably not going to come back, especially there. So what are you using as your surrogate? An elevated lactate. Clearly, we didn't have one there, but you have to assume that the patient's lactate is going to be elevated. Does it have to be from cyanide? No, it doesn't have to be. But what's the risk of giving hydroxycobalamin to the patient? Fairly minimal. And also, looking at the gas, looked like the patient was a little bit underventilated as well. They're not appropriately compensated. So I agree with what Eric said. Ruben, I don't think we had that gas initially. So in retrospect, having to make some appropriate ventilator changes to make sure that we are helping the patient compensate for their acidemia.
Yeah, it looks like I just remember that I have the actual chart in front of me. So it looks like your initial settings were 20, 450, 8 at PEEP, 100%, 0.8. Getting pressures of 25, like an 8.6 a liter minute ventilation, 1 to 3 roughly. So pretty standard settings. They at least turned the rate up from 12 to 20, and put a little PEEP on, so a little more PEEP. So, all right. So the transport team gets there. You guys consult, fentanyl, propofol, give the cyano kit, get labs, right? And Jay, you placed this IO, right, to be able to give the cyano kit. Was that the reason for the IO placement? Because they only had one point of access.
Yeah, the one point of access was the IO on the right side, and I got an IO on the left side. So we had bilateral IOs.
Bilateral IO. So no intravenous access. Like
there may have been, from my knowledge, like I think there was one, because there was a part of his left arm that was not burned. I think they were able to get like a 20 in there.
Okay. All right. So yeah, I mean, we kind of got to this point, and this is when I kind of want to query the group on. We're going to kind of do this twice throughout this case, and we're going to kind of have a stop point here about how we approach fluid resuscitation on this patient, right? And so everybody sort of knows the Parkland formula: 2 to 4 mLs per kilo total body surface area. I've heard some varying opinions on whether we still do Parkland or whether we do 2 versus 4 versus just give fluid sort of in the pre-hospital environment. So what are you guys doing at Mac? What's your guidance to your team, Ben and Jeff?
So I think this is where, initially I agree with you that the guidance isn't necessarily clear here, because the major pathology here can be multifactorial. So we do recommend initial bolus resuscitation. I think it's less clear that people benefit from getting all the fluid in 8 hours. So the focus is on ensuring eubulimia and treating hemorrhagic shock, as opposed to adhering to a rigid formula, because I believe there's less evidence for that. So sorry to give you a non-answer, but I think this is really important for the mental model that we try to adopt when we're dealing with patients like this, right? So getting down the rabbit hole of a particular formula or a particular resuscitation strategy can be very difficult, because from all the stuff that you said, we've got multiple things going on. But our guidance is initial fluid bolus. It's less clear that it's needed in pediatrics. But I think that the pendulum is probably swinging away from giving the trying to make up the entirety of the deficit within the first 8 hours now for Parkland.
So you're saying the pendulum swung away from that 4 cc's per kilo divided in half, give half of it in 8 hours, like that, just really super aggressive front end fluid load. Okay.
Yeah, I would agree with that. I think in part because we have probably overestimated traditionally the burn amount, and we're just giving these people so much fluid that when they arrive, at the burn center, and then the burn center has to then deal with subsequent consequences of, having these really puffy patients, it makes things difficult. So, you talk to the burn centers and they're like, just do some boluses, or we prefer you to be on the lower end of that range of cc's per kilo per total body surface area. Then do the traditional 4 and then just blast it in right within the first 8 hours. So I totally agree with what Ben's saying.
I would just add very briefly that this is fascinating. You had mentioned initially that this guy was found in his yard, and first thought, I know what a meth lab is, being from Baltimore, so this must be like a Baltimore County call. All due respect, but the issue is, we don't want to make people worse. And I think this is where we have to be able to take a step back. And I'm sure we'll talk about this because this call is already surprising, is that sometimes we get so focused on, well, it's a burn, we've got to go ahead and give all the fluids in the entire world. Well, if you worry about, let's say, pulmonary contusion and pulmonary edema, we could conceivably make things worse. So I'm particularly interested in how we approach resuscitation, because we've got multiple systems that need to be resuscitated at once. And sometimes protocols can lead you astray, especially if that's the exclusive focus. But yeah, I agree with all your points too there, Ethan.
And I think this case is additionally challenging. I mean, if you go back to those labs that were admittedly rather bland except for the CO, the bicarb of 9. He had a creatinine of 1.6 and a hemoglobin of 18, and unless he had like horrific lifetime COPD, I mean, a hemoglobin of 17.8 is significant. I mean,
Yeah.
that is not normal, and it's remarkable that you can see that already. I mean, I don't know what your interval. You know, I work at a place with no services. I see a patient come in the door, and I'm already calling for transfer before I've seen the patient, and I'll just muddle my way through the rest of the consult. And I presume that's what happened here. Like they said, "Oh shit," and called, and then they intubated the patient. And so it's remarkable that those labs are so messed up already. Like he's already that behind, presumably on fluids, which I think makes all the formulas like out the window, because like who knows what's happened already. I mean, and coming from Western Pennsylvania, the meth lab explosion center of excellence, this is quite common. And I think here we have the advantage of a Foley catheter, and look at, are they peeing or not? I think, calculating half a cc per kilo per hour, 1 per kilo per hour from St. Agnes to Bayview is irrelevant, but we'll all be involved in the eventual Meritus explosion where this is not irrelevant. So, and the only other thing to add is that, if you look at like the EMS fellowship textbook, they talk about rules that I've never even heard of. I mean, modified Brook is 2 per kilo.
Yeah.
And then, so the studies between modified Brook and Parkland show that they only give less fluids, the outcome's no different. And then there's the pre-hospital rule of 10 formula is also in the book, where you just take the estimate the burn and then multiply it by 10, and then add 100 if they're very heavy to come up with their initial fluid bolus. I mean, there's so many different data points that I think urine output is probably the only true good marker, though it's challenging in a 20-minute transport to see if they're peeing.
Yeah,
Sure.
The other thing that I want to add to that is to Dr. Launer's point that this patient was in an explosion, and we have to remember that there are forces involved in the explosion that are going to create internal pathology that we're not going to see on the outside. Dr. Launer mentioned the pulmonary contusion piece of it, and we're already worried about the airway. So you've damaged pulmonary vasculature, and any significant fluid bolus over a short period of time is just going to worsen the airway picture, and then you're going to be even more behind from an oxygenation ventilation standpoint.
Yeah, I definitely wanted to discuss that piece of it and sort of the concurrent injuries, and then the blast stuff. But the one before we get to that, I did want to ask if any of our MedStar colleagues, we know we had both Christiana and MedStar. We invited both Christiana and MedStar. I just wondered if anybody from either one of those teams had anything to add from what do you guys do? What's your protocol look like, or what's the guidance on your team? Okay. I guess we don't have anybody from there. That's fine. Okay. So before we get to we'll do it now. So given the fact that this patient had some sort of blast injury, right? Let's say the report is their house blew up, right? Are we going to do less of a fluid resuscitation under the assumption that they probably have some sort of blast injury to their lungs, they got hit with a piece of the house in the chest? Like there is concurrent trauma potentially. And I don't know if you saw it, Jay, I don't know if you saw any bruising or any signs of trauma, or you could see that over the burn. But did you guys have any concern for trauma as you looked at this patient, either from a ventilator management, sort of ventilators or like pulmonary standpoint, or even other musculoskeletal, head trauma, that type of thing?
Yeah, I mean, when we got in there, the pips were 25, so they weren't like super high, and he was getting like good wall motion that we could see, but he did have a significant laceration, I think above his right eyebrow, and they had not had a head CT yet, so there was concern for, are we going to shock trauma, or are we going to continue on to Bayview given possible trauma to the head?
I was waiting for the Maryland multidisciplinary jurisdictional trifecta consult. So thank you for that. I was waiting.
We're here for you,
Ben.
Ben.
Person could be maybe a prenatal center too. If the person was pregnant, that throws everything also into it as well. So, but I'm glad we capture all the complexity.
It brings it brings up the question of, does imaging, particularly with the large lac to the head, or trauma imaging, right? The Shan scan, the trauma scan, whatever, does that delay transport? And does it matter if the burn center is also a trauma center? Does that change that decision? So I'd be interested to hear folks' thoughts on that. I know trauma always trumps burn, but what if the burn outweighs the trauma from a severity standpoint?
Sam, this is a great question. And the medical
I
director.
pride myself on asking those. So
I know
thank you,
you're doing
Eric.
great, Sam. The medical director group that was on speakerphone had some spirited discussion about, should we get the head CT at the facility or should we just load and go? So I'm curious what other people have to say or what their opinions about what they would have done.
All right, I'm going to throw myself on the sword here because I think there are times. So Jeff had mentioned this earlier, that we have to figure out, the pre-transport plan. And first of all, this situation is exceedingly complex, and there's probably no correct answer. But once we decide that a patient is critically ill with the potential for major trauma and major burns, I think this kind of tilts the spectrum in medical decision-making with respect to going. Anybody that is not at a high-performing trauma center that tries to order a CT, I don't know the last time you've been to this ED, but it takes a lot of time. And the question really is it going to affect your management? Now, in Baltimore, we are actually quite blessed that we have trauma burn centers that often coexist. So I think this is where we have to be able to rely on the crew to make that decision. So this would be a very difficult decision if the patient was obtunded with blown pupils, because obviously herniation changes management and downstream therapies, and time becomes a bit more imperative. But if the patient is moving, if the patient has purposeful movement, if the pupils are reactive, I think we really got to consider where to go. And that's going to be predicated upon the assessment of the crew. Because yes, trauma trumps burns, but in terms of what the overall synthesis is, that Bayview can certainly take care of everything. On the other hand, if the patient is otherwise unstable, we do a lot of those secondary transfers. I would only add that, I appreciate the discussion, but we're not going to be able to get this correct because, number one, we don't have the time, and it's often difficult to get the entirety of the diagnosis within that encounter, especially when we're dealing with a patient that really needs to go. So I would say, based upon what you've told me, I would not advocate for a CT, provided that there's movement and somewhat stable vitals. And then I would rely on the crew to say, where do you think you can get to? Clearly, there's a lot of burns. Clearly, the patient has traumatic injuries. But if they're hemodynamically stable, I would say either Bayview or probably shock trauma is an adequate initial first step.
Sure. Thoughts from anybody else?
It's so tricky because the trauma, really, you're going for bleeding control. That's really what you're going for. The difference between a level 1 and level 2, we don't all only practice. I mean, this is a mostly Maryland group, but most often neurosurgical capabilities is the difference between a level 1 and level 2 trauma center. That's typically in most states what makes the big difference between a level 1 and level 2. How quickly a neurosurgeon can be there, or can they do neurosurgery? I think that if this guy had a horrific neurosurgical injury, he's probably just dead. Between the neurosurgical thing and the burn, it probably doesn't make that big a difference. But in this case, letting hemodynamic instability is a very complicated question because, as we've already talked about, it's almost assuredly from cyanide and less likely from trauma. And so I don't know that there's any measure besides a pan scan that a pan scan with all the contrast, which someone's going to have a heart attack because his creatinine's already 1.6. So it's like nothing is good about this. And I think in my mind, you just go to Bayview. And if it's a neurosurgical catastrophe, you say sorry and deal with that later. But I think this is going to be burn management. I actually, Baltimore City doesn't currently carry cyano kits. I don't know if I'm allowed to say that on a recorded line. There's discussion of people carrying it. And so I asked Shock Trauma if they ever use it. They used it twice in the last 12 months. So I am sure we could do it. Everyone's smart there. There's pharmacists there. But managing someone with cyanide poisoning is not something they're experts at. And you guys, Bayview gives out cyano kits. They gave it out, I think, 56 times in the 12 months prior to me inquiring. that's that level of expertise and managing a patient where the labs are all jacked up because of this cyanokit it's not for nothing. So I think the answer is Bayview, but don't tell anyone at Maryland I said that.
The answer, we all say that we should probably get out of that sending facility, right? I mean, that's always difficult because I'm sure St. Agnes would like nothing more than for us to stay for additional diagnostics. Very difficult question, though. I agree.
Yeah, I think from an academic discussion standpoint, there's a lot of things to weigh in. We had the benefit, of knowing that Bayview does have neurosurgical capabilities. So in that spirited discussion that Dr. Garfinkel was referencing, I was pretty adamant about leaving prior to CT imaging because I didn't really understand how it would change our management. Because again, the discussion is very, very interesting. There's multiple points, but again, Bayview has the benefit of having everything that patient would need, even if in a positive CT scan. And the sending facility really didn't have any resources to treat anything that they found on that CT. I don't know.
The last sort of point I want to make is I think communication is really critical here. We have to effectively communicate with whatever that receiving facility is. If we have still clinical concern, but are unable to get the diagnostic testing we want, right? So like, hey, we're coming to you. We still have this question that has yet to be answered. We need you guys to know that and, work out a plan to hopefully get the imaging done at a, in a reasonable time frame. It's not out of the question sometimes that you stop through, an emergency department or wherever the scanner is and get registered, get scanned on your way up to wherever your final destination is, this being obviously the burn ICU. So I think good communication between facilities, transport agencies, and receiving facilities could really, I think, decrease some of the anxiety about, we also want to be perfectionists. We want to be complete in our evaluation. It feels a little bit uncomfortable that there are a lot of unknowns here about the patient, yet we're still responsible, right? Like if we're in any of our own emergency departments, we're scanning and we're managing the burn and we're giving hydroxycobalamin because we can do all of that. But when we're away from that, it makes it difficult because now we have to say, well, I would ordinarily do this if this patient was in front of me. I'm going to have to sacrifice this to do that. All made more complicated by the fact that this patient was going to be hemodynamically unstable. Again, is that due to at the cellular level from hypoxemia and hemodynamic effects of of cyanide? Is that secondary to now they're bleeding from the explosion and they really need blood, not, lactated ringers, right? So all of this sort of comes into play as well. But I think the team did a great job sort of fairly quickly having this spirited discussion. So we're not just kind of, doing the analysis paralysis thing, which can also plague us in this situation.
Our Adams Callie just rolled over in his grave on a Maryland recorded line that nobody needs ringers. Jeff, whatever you said pales in comparison to that heresy, just wants to point that out there.
I'm going to shift gears real fast before too many more people roll over in their graves. What is the trigger for that cyanokit? And is there does the cyanokit somewhat fall under the grouping of it can't hurt to give it? Like, what are your triggers for giving a cyanokit? That you were in an enclosed space? Is that just check that box? Like, is that the only box I have to check to get a cyanokit? Like, I was in an enclosed space fire?
So I would say enclosed space, just looking at the burn and going, that's really big, or that's not that bad. And then the airway involvement as well. So I think those three things together, when you combine them, for me at least, whether or not there's anything else, preemptively giving that cyanokit, because as you mentioned, Sam, there's no real harm in giving it. The burns folks will, they will pitch a fit that it's going to cause kidney injury. But my argument is, are they having kidney injury because of the cyanokit, or are they having kidney injury because of the significant tissue breakdown because of the severe burn?
Okay. And what are the side effects? If I give a cyanokit, and to Jeff's point, it's like something that's not given very often a lot of places outside of burn units. What are the things are there adverse effects that I need to be aware of as a transport clinician giving this? Like, is there something I need to be on the lookout for from changes in my vital signs that I'm going to see on my monitor, changes in hemodynamics, those type of things. I mean, I'm not drawing serial labs, so I'm not going to see the weird lab stuff that I know comes off of it. But are there things that I need to be prepared for as a transport clinician? Asa?
Yeah, so really the labs is the main thing. There may be some effect on, pulse oximetry reads. Although, again, not super convincing in the literature. Some people say yes, some people say no. From the immediate transport perspective, there's not really a whole downside to it. Yes, be aware to see if there's an acute change of the pulse oximetry reading, but other than that, not really. And from my perspective, again, the literature will say a lactate level greater than 8 to 10 or 8 to 12 is often quoted. I'm not necessarily going to wait, and I guess, we could do point of care lactates, but if not, like, this gas is evidence enough. Or if they're hemodynamically unstable, that checks a box for me.
Okay.
There are fire departments, we in Howard County carry it on our supervisor vehicles, and our expectation is, you have a hemodynamically unstable burn patient that we're RSIing, that needs to be intubated, they're getting the hydroxycobalamin, they're getting the cyanokit. And there's certainly a lot less downside nowadays than it was the old Lilly kit. We'd have to think long and hard about, administration of the Lilly kit when that was the first line, particularly when we have competing cellular toxins such as CO, right? Because in that process, we're making methemoglobin. Methemoglobin does not carry oxygen. Now we have, hypoxemia from methemoglobinemia. We have it from some cyanide toxicity, and we have it from CO, right? So it was a lot more of a difficult decision before we had our current cyanokit, which is hydroxycobalamin, which is really only a precursor of vitamin B12. And the downside to that is certainly not as extensive as it was when we had to sort of weigh the risk and benefit when we had concomitant CO as well.
Do you know, can you run an iStat or whatever? I presume you use the iStat machine, or can you use your point of care device with after you've given it? Does it work? Does it contaminate the cartridge? I don't know the answer to that.
Yeah, it messes things up.
Like, to the point that you shouldn't do it, it's all invalid, or can you get any meaningful, like the pH, or can you get CO?
Oh, okay.
Yeah, I've actually asked that question to one of the reps. They said that they don't advise it. Anything more, they don't speculate on.
And then the only other thing, we talk about no downsides and all. This is a patient with limited access, and anything that's going to run over any period of time, I think losing an access point is a downside. And then, having been a very inept flight physician for a number of years, doing things you're not familiar with just makes everything harder. And unless you guys are giving it all the time, taking out a glass bottle, that's going to make your hands brown and going to be a mess if you're not smooth with it. And everything is weird about it. I think we can't forget about the clinicians actually at the bedside who are doing something they're less familiar with. I mean, again, the risk is very low, but in already a task-heavy environment, adding another task, if we don't think there's a benefit, I would argue against the kitchen sink approach, though. This seems like a very reasonable case. And then the last thing is the Bayview criteria, according to the pharmacist. I don't know if she was the trauma pharmacist or the burn pharmacist or whoever I spoke to. The criteria there are very, very big. You guys have talked about very specific times. They really advocate for throwing it at everyone. They even do entrapped in a car, and I presume that's from airbag, the airbag components, because she said it didn't have to be a car fire, just a long vehicle and entrapment. So they really are quite generous with who they give it to, according to this pharmacist.
That's weird.
Interesting.
That's really interesting, because all there is in the airbag, that dust that comes off can cause a pneumonitis, but it is relatively short-lived. I wouldn't think that it could induce any sort of cyanide toxicity.
Well, I think and I love the term analysis paralysis, but I think in terms of moving forward, we're all saying the similar things, right? There's not a lot of consensus because this is a low evidence zone. So I applaud the crews for doing the bilateral IO drill. That was probably pretty interesting, is what I heard, right? You've got multiple access points. I think we're talking about the risk versus benefit synthesis here for cyanokit. I think we all agree to give that as well. Fluid resuscitation, and importantly, we're treating all the ongoing concurrent hemodynamic abnormalities. Like we said, it's so difficult because we're not going to have all the information. And And I would further agree that all the triggers you heard, none of them was contingent upon getting another, point of care. So if you have that hemodynamic instability and the acidosis, I think in this case, that's enough, given this patient has multiple concurrent life rates at the same time.
So we'll keep moving there. These were the repeat, or this was the epoch labs that were gotten. So everything's fairly similar, right? He's more dehydrated, right? H&H is worse. No real changes on the chemistry, but the gas is profoundly different. And granted, I believe it was an ABG, and Jay, correct me if I'm wrong, but I think the original one was an ABG. This was a VBG, but like profound differences in the gas. And they were an hour and a half apart, Jay.
Yeah, it was something they had it. It was unclear as to how long it really was ago, and I don't know if it was a venous access or an arterial access. I don't, cause he didn't have an A line. I didn't have any evidence of a stick. I don't know where they would have gotten an arterial stick.
Okay, so maybe it was venous. Maybe even the first one was venous. But why such a profound difference in the labs? Like, I'd be curious why you guys think that there's such a difference in the labs. I mean, that was a substantial difference, and I can pop back to them, but.
Jay, remind me, were these labs before or after the cyano kit? Or during?
I believe those were before, and it was before you had gotten there, as far as I know. We got one pretty quickly. I remember like setting up the vet and then turning the epoch on. So, yeah.
So no discussion is complete without invoking the stat medevac lactic acid protocol, where they're actively extricating somebody and they've got to get the lactic acid level. And I would just suggest that the utility of routine screening labs for major trauma, right? We have to understand that there's always going to be confounders. So if our goal is to get labs on a patient that was just in a house explosion, when he was potentially apneic, when he was thrown on the ground in pain, there could be a lot of explanations as to why that gas looked the way it was, none of which may relate to the underlying physiology. So whenever we get those screening labs to guide our decision as part of an initial resuscitation, it's not that it's bad, it's just we have to understand that this patient may have not been breathing normally or at his physiologic baseline after he was thrown from the house. So I am very cautious with those labs, and I think the literature is very clear that yes, the lactic acid level may be a very good indicator, but it's always going to be confounded in the setting of major trauma. It's always going to be high, or usually going to be high, in the setting of bad perfusion, injury, or the initial response.
The thing that I'm puzzled by when I looked at this case in preparation for this, the thing I'm puzzled by is, why does this bicarb double? Like, I mean, it went from a bicarb of 9 to 21. So I'm still trying to wrap my brain around physiologically where in the hell he doubled his bicarb. And maybe somebody smarter than me can help me understand that.
They left the tourniquet on for who knows where they got. Okay. When was the gas taken initially? Do you know?
As soon as he got to the ED, right, Jay? The original gas?
The venous gas was taken pretty much right away.
And after he lost his airway?
So no, so the first one that was taken by the St. Agnes staff, I'm not actually sure when that was taken. It was presumably, prior to intubation or just after. And then we got ours pretty quickly, a venous sample run through our epoch. I would say within 10 minutes or so of patient contact.
All right, and I think I wanted to discuss the head CT delay, but I think we talked about that pretty extensively. So we'll keep talking about the case. Jay, you can, as a result of these consults and the labs and the differentiate and the proximity of our EMS fellow to where our crew was, we made the decision to deploy the EMS fellow. So he was taken to the bedside. So Kosh, you can kind of talk through this piece of it and give us an idea of what you saw and sort of decision-making at the bedside.
Absolutely. So what we had initially heard, this is during the medical director's powwow that happened when the consult was called, was the patient was considered for escharotomy, but the surgery team at St. Agnes had declined to do it because they said the pressures are fine on the vent. That was their sticking point for why they did not want to do it. So, and Jay, correct me if I'm wrong, but that was the primary reasoning behind that, right?
Yes, they just didn't feel like it was, I guess, clinically necessary at that time. But with the, I guess, foregoing the expected clinical course.
So I walked into the room, and I believe the exact order of words out of my mouth were, "Hey guys, how's it? Is that his SAT?" And so I'm seeing his O2 SAT starting to dip. And I think by the time I had walked into the room, it was 80, like upper 80s. And his pressures were in fact okay on the vent, but then we were also taking his blood pressure. I think it was on his leg somewhere. Jay, was it on his calf or something?
Yeah, I was on his leg. We had he had two the burns were too bad on his arms to take.
So we're taking blood pressures on his calves. And so I'm thinking to myself, okay, I don't know how much I trust this blood pressure. I'm seeing his O2 SAT declining, and the O2 probe was, I think, one of those nose clip probes, because he had one on his he had a sticky probe on his finger. He had actually one on each finger. I think he had one on a toe, and we're trying to get a decent reading because the waveform is just garbage. And so I don't know what his actual SAT is. I'm looking at the vent, and his PCO or his end tidal is not terrible. But the other report from Emma when I got in the room was she didn't think that he had great breath sounds on I believe it was the right. So I threw the ultrasound on his chest just to see what I was dealing with. And I thankfully had lung sliding on both sides. So at least as far as a clinically significant pneumothorax, I was able to rule that out relatively quickly. But just looking at the picture that I was presented with the declining blood pressure, the declining O2 SAT, and just looking at the burns and seeing they were quite significant. It was the entirety of the anterior surface of his chest down to the costal margin, and extending onto both upper arms, down to the forearms. He definitely had significant facial burn and burns on his neck. I looked at this guy and I said, he's going to decompensate en route. He's decompensating now. We need to do an escharotomy. And so I stuck my head out of the curtain and I looked at the folks at the desk and I said, call whoever you need to call for surgery to get them down here, because if they're not going to do it with the electrocautery, then I'm going to do it with the scalpel, and it's going to be a lot bloodier if I do it with the scalpel.
And I'm the EMS fellow from Hopkins. I am so upset that we weren't there. Number one, how did you deploy the EMS fellow? And number two, I cannot believe you didn't call us to come play with the GO team. I mean, there's Maryland medical protocol for this. I'm very upset that we were not consulted, but that being said, kudos to you, Cash. I would have loved to have been a fly on that proverbial wall, looking through the various SAT probes. Why, if you don't do this, that's just a great quote. It's going to go down in collaborative history. That is
Scooter.
perfect.
We
The
deployed
Hopkins dome is shining at St. Agnes. I'm going to get in his chest with a scalpel.
He was deployed on a bird scooter. Like,
Yes.
Oh, I mean, we're done. I think that was just great. It's a great case.
So the surgery team came down, and I don't know exactly what level of training this person was. I don't know if it was a resident, a fellow, and I don't think it was an attending, because when I asked who's going to do the procedure after I convinced them to do it, like I basically in 10 seconds said, look, this guy's going downhill real fast. I understand his pressures are okay. I'm anticipating that's not going to be the case in about 5 minutes. So we need to do this before we move. Otherwise, he's going to crash on us en route. And so the person that the physician that I was speaking to said, great, we'll get the Bovie down here and we'll go for it. And I said, who's going to do it? Do you want me to do it, or are you going to do it? And he said, and this is, I remember this distinctly, I and my co-fellow will do it. So I don't know what kind of fellows they have at St. Agnes. I'm not familiar with their graduate medical education layout. But so this gentleman and another woman came down. Those two physicians were setting up to do the escharotomy. And I'm sitting here watching his pressures and his O2 sat and realizing that we need resuscitation while we're doing this. He's starting to move. We need additional sedation. And there's, quick look around, no other physician in the room. And I was then informed that the attending physician was a couple rooms over dealing with a code after an MI. Like the patient had a STEMI and had then actively coded. And so they were resuscitating that individual. So I basically told the surgery team, look, you guys cut the chest and I will do the sedation and the resuscitation for you. And I quickly walked out of the room across the way because I realized I'm going to sedate someone in a facility that I have no credentials at. And I walked up to the EM attending and I said, hi, I introduced myself. I'm the EMS fellow from Hopkins. I'm the medical director representative for Lifeline. And this person needs an escharotomy before we go. And I'm about to give ketamine in your ER. Is that okay? And he basically looked at me and he said, do whatever you have to do to get this guy out of here. I don't know why he's still here. So I went back into the room. I started asking for various things, ketamine, fluids. And I asked for I looked at she was a nurse educator. It was the ED nurse educator who was the only other nurse in the room when we first got there, right, Jay? Or it was her and one other nurse.
Yeah, there were two nurses that were in there kind of helping us out and like running things, like getting us more bags of fentanyl and stuff like that. And there was also a PA like popping in and out.
Yeah. And so I looked at this nurse educator who she was instrumental in doing all the things for this person. And so I looked at her and I said, I need neosynephrine sticks. Or not neosynephrine, sorry, phenylephrine sticks. She materialized them seemingly out of thin air. Like anything that I asked for, she put it into my hand. It was amazing. And so I'm running the resuscitation while they're cutting his chest. I wasn't paying any attention to the cuts they were making. And after they were done, we basically packaged up and decided, we got asked a couple of times, all right, are we ready to go to CT? Are we ready to go to CT? And I said, we're not going to CT. We just need to go across town. But Bayview has neurosurgical capabilities. And then I said, I'm going to call them and update them and tell them we need burn at bedside when we arrive. And I cannot remember who I spoke to from the ED at Bayview, but he basically told me we're going to be ready for you when you get here. So that's kind of where we were at. And I was fiddling with the vent as we were on the way.
What
So
was
you
the
had some-
total interval of all of this? Are we talking like 10 minutes, an hour, 2 hours, 6 hours? Like how long was the scene time?
From when I got there, I think we weren't there for more than an additional, what, Jay, half hour?
Yeah, I would say prior to you getting there, maybe like I think we were there for like 20, 25 minutes, and then you got there, and then it was like 30.
The bedside time was roughly 2 hours.
Okay, so we were way off.
All right.
No, I mean, just like from the time you guys got there to the time the calls and and get everything done, the bedside time was roughly 2 hours, according to the chart. So it looks like according to the chart, it looks like during the course of the escharotomy, the patient got substantially more hypotensive and hypoxic, the increasing respiratory support, SATs plummeted is probably the best way to put it. SATs went from high 80s to most of the transport looks like the SATs were in the 60s, and increasing respiratory support, increasing PEEP. Like you said, you did some ventilator changes en route, and patient was placed on levo, and you gave a couple pushes during the procedure. It sounds like, and then taken to Bayview where you were met by the entire crew. It sounds like. So hemodynamically stable with the vasopressor support, but profound hypoxia during the entire transport. So my question sort of to the group is, where does the hypoxia come from? So the chest is now escharotomized. Is is the hypoxia most likely a result of some sort of lung pathology, right? Sloughing of the burned airway. And in that case, what are our ventilator strategies? Like, how do we optimize this patient on the ventilator? Is it a PEEP strategy? Is it more FiO2? Is it an extended I time? Is it APRV? Is it crash on the VV ECMO? Like, what is the best sort of strategy for these patients?
So let me just chime in for a sec. So Kosh did a nice job sort of helping at the bedside. He, made all these clinical decisions, obviously, reached out to me and called so we can discuss kind of what the plan was moving forward. And one of the things that we had, that I was really thinking about when he called back was what the issue is with respect to this more profound hypoxia. We had at this time already given the cyano kit. So there were a couple of things now that was going through my mind as to the etiology of the hypoxia. I'll sort of, leave that open to the group's discussion before I give my thoughts. But we did make the decision to forego the head CT, really now sort of driven by the clinical change in the patient. A lot of this was sort of all happening around the same time between doing some resuscitation, giving the cyano kit, the bedside team doing the escharotomy. So, this whole idea of make one change and see an effect was not really what was at play here. There were a lot of things sort of going on, and then we were getting a whole different clinical picture with respect to the patient. So again, one of the things I was wrestling with was, okay, hypoxia. Why? What are we going to do about it? The hemodynamics obviously was concerning, but we were able to, temporize that with some vasopressor support, and that really was no longer an issue. But it was really this profound hypoxia that kept sort of plaguing us throughout the transport.
Is the cyano kit play any role in this? Does that throw off the SAT probe? Could it be sort of, was the hypoxia being masked by, I don't know, the cyanide toxicity that we're trying to fix with the cyano kit? Or maybe this patient's been on oxygen long enough that we've cleared the hemoglobin that's falsely like reading the saturation from a carboxyhemoglobin. Like, is the hypoxia real? I guess that would be my question. Like, this is a very, very profound change.
That was exactly the question I was asking myself, because as people, some may know, most probably don't. When you give that cyano kit, it does change the color of body fluids. And the way that pulse ox probes work is transmission of light through the tissues and how much makes it through to the other side. And that the light is a very specific frequency that gets absorbed. And so this is after the fact, I did a brief lit search, and
Don't give anything away yet. Let's let the rest of the crew chime in.
But one of the things that you and I had discussed, Dr. Margolis, was whether or not we should give another cyano kit in response to this hypoxemia. Excuse me. And unfortunately, there was not another one available, but that was definitely something that came up in our discussion.
And Kosh, I've never been a part of a chest escharotomy, but my understanding is that, it looks easy to just like, cut and release and it's fine, but you really have to get the both sides, the top and the bottom, and you really have to cut. It's not just like a little incision there. Did you feel confident? I suspect your N is 1 on the chest escharotomy now. So your prior experience is not helpful, but was there a change at all? Did the chest like puff up all of a sudden, or what happened after these two people? I've just been Googling St. Agnes. I know so much about the hospital now, and I still can't find a fellowship. But after these two fellows did it, was there any change in the physical appearance? Like, the chest should puff out, I would think, both from fluids and from tension release.
So yes, the chest did puff out a little bit. We heard more significant breath sounds, but unfortunately the hypoxemia persisted, and we didn't really see any change in the pressures on the vent. And yet you're correct, my N is 1. I won't say too much other than I was interested by the placement of the incisions in the chest wall. And I'll just, kind of leave it at that. So again, being laser focused on the resuscitation part of it and not as much on the incision part. I don't know if I would have been I don't know that I would have necessarily felt like it was my place to speak up about what they were doing, considering my N is 1, and these are presumably, hopefully well-trained surgical physicians, whether or not they're still trainees, that have potentially done it more than I have. So,
Arissa, I'm gonna go out on a limb and say you did some time Bayview or ORs during your residency, doing burn ORs. Have you ever seen sort of alterations in SATs and the physiology and from a ventilator or airway management standpoint with the circumferential chest burns, those type of things?
Yes, we saw them all the time when we did our burn rotations at Bayview. Often what would happen is that they would be in the ICU, they would have increasing PEEPs, decreasing basically exactly what you guys are seeing. And then as I apologize, I don't know who mentioned it, but the way they cut, it's very specific to get the release.
Okay.
So you may have some increased ability to have chest wall excursion, but it's very specific where you have to cut to get the full actual increased tidal volumes. And that's what we typically look for, is the actual tidal volume, not only your PEEP, but then also your SAT probe. And the cyanide typically, when we inject it in the OR, it typically that decrease, it will last for about a minute. I was curious, I'm actually sitting here looking up how long it would last with the cyanide kit, because that should stick around a little bit longer, but that could have been also playing a factor into why the SATs were so low, but it shouldn't have lasted that long.
Okay. So transient change in SAT when you give the kit, but not for 20, 30 minutes like we saw. So probably more of a pathophysiology reason for the hypoxia as opposed to sort of a false reading.
That's what I'm thinking, but I'm sitting here looking it up because I had never, when I've given the kit at shock, it was a transient, but then it was nothing that stuck around in my head thinking that it remained low afterwards.
Okay.
And usually it was only a minute that it remained transiently low.
And if I do the escharotomy right, what am I seeing on my ventilator? I'm seeing increased chest excursion, which is going to give me increased volumes and lower peak inspiratory pressures. Is that
Yes.
sort of
Yeah.
the mark of, okay.
Yeah, but then that's what you should see. But then because, as you guys mentioned, he had that blast injury, was whether their peak pressures, was that because of a external restriction, or was that because of more of a pulmonary injury? There's kind of multiple things here, but you should see, just looking at the chest, you'll see increased you'll be able to see the chest rising. And actually, a lot of times when they would come to the OR, you'd actually see like the right side rising higher than the left side. It would just be a discontinuity. And then once they would do the release, then all of a sudden you would just see these everything would just improve from that standpoint. And you typically have to do sides and front when you do them.
Okay.
and in this case, it was just the sides that were done. They had not made the transverse incision, and and the only other thing that I'll add to the hypoxemia picture is the report we were given was there was a significant amount of char in the airway, a significant amount of soot. So.
Okay. Yeah, I mean, that's the gist of it. I think we've talked about a lot of stuff. I know that Ruben got a chance to follow up with the folks at Bayview and sort of got a little bit of an idea of this patient's clinical course and sort of how they did in the burn unit once they made it up there. So I'll let him sort of fill that in.
Yeah, I was attending the night that patient had got there the day before, and one of our residents in emergency medicine was rotating through the burn unit, so he was actually there when the patient arrived. So when the patient got there, the team actually extended the escherotomy. As Kosh said, it looked like there was just 2 lateral incisions, but our resident was able to assist with completing the escherotomy at the bedside with Bovie and the burn team there. Didn't really help much with the SATs at all. didn't really do much. The only improvement that actually happened was after they bronch the patient and actually lavaged and cleaned everything out. After that, they said that the stats like dramatically and almost immediately went up. The overall course of the patient was very poor. I think they spoke to the family and gave them the news that patient was probably not going to make it with all the damage that had been done. But I haven't followed up with them since then.
Do you know if they ever got a head CT or any other trauma imaging? Did you ever hear about that? Okay.
I'm sure they did, but
Yeah,
I
but
don't know if there's any.
sort of no, we don't know if there was anything significant.
So that,
I had heard that the CT was negative. They went to CT
Okay.
like before we even left the facility to go back to Hopkins. So I mean, I don't know who I heard. It was just through the grapevine, but I heard that it was.
yeah,
Great.
there was no penetrating injury, which was what we were initially concerned about with this
Sure.
large laceration over the eye. But yeah, the CT showed that it was a soft tissue injury. It was just that, it was a laceration. And there were nothing else as far as what I looked at when I looked him up. There was nothing else significant. So and I did follow along afterwards. I don't know if anyone else is going to bring this up, but they ended up making him comfort care, and he did expire quite quickly after that. So
One of the things that I spotted in the chart, and kudos to you, Jay, and Emma for your charting on this, but the inspiratory resistance, the RNs on the T1 was somewhat elevated. It was you guys had it down as 20. So the patient had some level of inspiratory resistance, some airway constriction. I don't. Is there a role for inhaled pulmonary vasodilators in this patient? And albuterol, Atrovent, something like that, to sort of vasodilate that airway. I don't think that's going to fix anything, but is there a role for something like that?
I'll jump on this one. I think there's not a ton of, if you're having a lot of issues with your RNs, when you're starting to have, ventilator issues, I think you could try to do some inline bronchodilators.
Sure.
Do I think that's going to fix the problem? No, I don't think it's, secondary to bronchial constriction. I think it's secondary to airway edema. And obviously now that we all know the end, it's, also secondary to a bunch of soot and soot plugs throughout the patient's airway.
Yeah.
I think everybody was sort of spot on that, the hydroxycobalamin, the cyanotic could probably affect what we're reading with in terms of the pulse oximetry, but it shouldn't last as long as it did. So in that case, what else is going on? Well, the what else was that, his airways, large and small airways, were really plugged with all this soot-like material, which, as Ruben said, improve once they bronch the patient. So, can you give bronchodilators? I guess you can. Is it going to make a difference with the RNs? Inspiratory resistance? No, because I think it's secondary to airway, airway edema.
So we're adding bronchoscopes to the.
We're adding
ambulance and
bronchoscopes. Yep. To the ambulance and helicopter, and
pulmonary lavage is the new skill that we're all
training
gonna
all of us to do that. Larissa, you're in charge of helping with
Yeah.
that. That'd be
I
great.
love it. I was going to add one thing is actually you guys using ketamine. That's actually we'll use that for bronchodilators. So if you have, since you can't do a bronchial lavage, that's a second line, or you can use epi to help with that.
And that's actually one of the reasons that I went with the ketamine during the escharotomy, was because I'm thinking maybe we'll open him up a little bit with that. And I didn't want to give him more propofol because he was becoming hypotensive, but then I was also managing that with the push dose pressors. So I don't know. Just
Yeah, I just, first of all, it's an excellent case, and good job to everybody involved. And we joke around, there's obviously no great model for all these variables when they present at once, but I also think this case illustrates some good things, and it really illustrates our codified approach to how we deal with these patients that are crashing. I also would suggest that, the more tools we have in the toolbox, when we talk about inhaled pulmonary vasodilators, the more difficult it gets. I mean, we have a very limited amount of time to make decisions about, do we stay, do we go, and what do we do? And it's interesting, you could also make the case in this patient that this is a load and go case from the beginning. I would just say that in this, like we did here, every intervention that we do, especially in the setting of a patient that is crashing from multiple etiologies, we should try to measure to the extent possible. It's interesting, for example, when we look at it, the hypoxia wasn't easily explainable, but there were some issues on the ventilator and some measurements of the ventilator that indicated that maybe it was not all chest wall restriction, for example. So I'm very torn, because one thing we don't have is a great protocol to work through the medical decision-making and all the complexities while we're confronted with somebody like this. So kudos to the Hopkins crew for being decisive, for looking at their measurements, but I think it's important to also keep a very clear kind of mental model of what we're able to do in transport, what we can bring to the bedside, and when does that really tilt the balance to stay and play versus to evacuate and transport to a trauma/burn center. Very interesting case, lots of variables.
Yeah, Dr. Lawner, you're much nicer than I am. I think that, you're saying it much nicer. You never want to fault a group of people for, trying to help out and trying to do the best that they can for patients. What I'm about to say, I can say, because I was in the room, part of the group making medical decisions, right? I think in some ways we missed the mark on this patient from the beginning. I think what you're saying in a much kinder way is that this patient was probably a load and go from the beginning. But, I think, we make medical management decisions all the time based on interventions and limited information that we have. And, we live with those mistakes. But what we always pride ourselves in is really appropriate prioritization of the problem list and the interventions that need to happen, right? Those are the things that we take pride in, that we are supposed to be the experts on. And I think on this case, we kind of went down this rabbit hole, CT imaging, escherotomy, and we failed to really identify an intervention that was, time dependent in terms of the bronchial lavage, right? And I think that we ended up going down this rabbit hole, spent 2 hours at the patient's bedside, when if you go back and look and seeing what was really going to change management, a lot of things that we did really didn't, right? So I think that this patient, like you're saying, in a much more kinder ways, was probably a load and go from the beginning. And I think as a group, I think we may have missed the mark in terms of appropriate prioritization of interventions.
I mean, as a clinician at the bedside, I think it's hard to arrest that sort of clinical momentum of you sort of get caught up. And it's interesting because we talked a little bit about this in the last quarter, right? With the case that Cody and Ben presented with that really, really sick hemorrhagic shock patient, and sort of that clinical momentum of where we're like going down that track of like arresting that clinical momentum is difficult. And as a crew member at the bedside, you sort of get caught up in like, fix this, and it just sort of keeps pulling you down the way. So I think it's difficult, but I think it's something that we need to be aware of. And I think it's something that we need to stay cognizant about how we do arrest that sort of clinical momentum of, but I need to investigate this and we need to fix that. I think it kind of goes to the fact, the question of like, is the enemy of good perfect? Or is that, I don't know if that saying is even right, but you know what I'm saying?
It's good.
Yeah.
It's good.
Yeah. It's good. Yeah.
Ruben, I respectfully disagree. I think you're being a little harsh. We adapted, I think, as we went, and this was a very challenging patient. You don't know, you'd rather have the resources when you can, but I don't even think this patient was bronched immediately on arrival. I think they waited several hours till they got bronched. And nobody was really thinking about that at the time.
I think they went down the same rabbit hole, because I think when your priority list is a little bit off base, the problem, like, it has tremendous downstream effects, right? Because then you start troubleshooting the wrong issues, and it adds more and more layers to the wrong problem list. I mean, we see it all the time. And I think the same thing happened to even the burn team. When the patient got there, they were like, and this is a recorded line, but they were like, what is this escherotomy? This isn't even appropriate, right? They like prioritized, oh my goodness, we need to extend the escherotomy, and they got a bovie and they went to the bedside, and they went down the same rabbit hole, right? That we talk about all the time, like a lot of things that happen, in the emergency department carry on, throughout the patient's stay upstairs. And it's that same kind of momentum. And again, I think we pride ourselves on the right priority list. And I don't know if we did in this case.
I will say, Eric, to your point, that it is it's very difficult. I would, on a recorded line, I think our institution we're expert in in adding those barriers and the cognitive sort of confusion. So I do think one positive in this case even if we were off base or the priorities are relatively mismatched, it's important to really talk to people that do transport, because a lot of times who you call is just as important, right, as what interventions you do. And a lot of times, if you were to call, let's say, a pulmonologist, because we have a very different medical control model where we don't always have the luxury of Jeff Nussbaum or myself or Ruben or Eric on the other end of the phone. So again, it always comes down to the clinicians and resourcing the clinicians and backing them up when they make those decisions predicated upon a really crappy amount of information, because nothing is ever perfect, as Sam said. But I do think the best chance these patients have is by talking to medical directors with at least a transport mindset, because ultimately we really want to be mindful of, where does the patient need to go? What's the definitive care situation? And can we provide that where we're at?
And I think the big thing that we think about in the transport setting is, how do we keep this patient from crashing on us while we're transporting? What interventions can we do when we have the resources available to prevent decompensation when we effectively have little to no resources and we're moving at, well, it's within the city limits of Baltimore, so moving at 25 to 30 miles an hour depending on traffic. So prioritizing everything that you can do so that when you aren't able to do things and you're in a tight space, you're not wishing, oh, we should have done this, because maybe then we wouldn't be in this situation.
I think we have hindsight, obviously, at our disposal right now. And the call was obviously very dynamic. From that initial discussion between the group of the medical directors that was in the room, things obviously continue to evolve and change. And while certain priorities were identified initially, those priorities obviously change as the case evolved. I'm proud of the job the team did. Proud of the job our transport crew did. I think they ended up getting great care when they arrived here. And again, that's why I love sort of reviewing these type of cases, because we have one perspective when we're in the middle of it, and we have a totally different perspective when we're looking at it from the outside, now that the craziness of the event has calmed down and we can look at it very, very objectively. So definitely appreciate all the hard work that was done at the bedside, all the hard work that was done by the physicians while consulting.
Ben Launer's
And
Launer.
Ben Launer still is the funniest guy I've ever met in my entire life.
Ash, could you just give us the one-liner that you said to the St. Agnes Surgical Fellow, just one more time, because I want to use that tomorrow at Shock.
I love it. I love it. Kosh, you're on mute if you want to give your one-liner.
No, it's all good, man. Great case. Always difficult, very humbling what we do, and I'm glad we can discuss it in this forum. So,
Man, how many times have you changed your background during this?
It's called helicopter envy and otherwise insecurity. I'm always humbled by the medical decision making going on here, so I want to make sure I touch all the bases.
All right, thank you to everybody. Before Ben changes his background again, we're gonna end this. But I appreciate everybody being here. Good job. I'm not fast enough. Thank you for everybody for being here. Thank you to all the folks who chimed in on the panel. Thank you to Jay. Thank you to Emma for being here and bringing us this case. And I think you guys did a phenomenal job. And it's always tough to be the crew that gets their case talked about. And we all have the benefit of hindsight as we look at this case. So thank you to everybody. And we'll see you guys next quarter.
Thanks, everyone.
Thanks for having me.
Thanks, everybody.
job.
Thanks, Sam.
All righty. Take care.